So good morning to all of you. So we'll start the instruction course on simple solutions to maximize the outcomes in vitreoretinal surgery, including scleral buckle. We have a young brigade of doctors from vitreoretinal surgeons from Chennai, and the coincidence is all of us were trained and spent some part of our lifetime at Shankar Netralaya. So we will start with the scleral buckle surgery. Maybe nowadays the indications and the surgery is coming down, but still it has an important vital role in vitreoretinal surgery. So I would call upon Dr. Bragadish to talk on scleral buckling surgery. He finished his fellowship at Shankar Netralaya and he is owning his practice at Chennai. Dr. Bragadish.
Thank you, sir. Good morning to one and all. My topic is tips and tricks in scleral buckling surgery. At the outset, I'd like to say I have no financial interest in this presentation. Moving on to introduction, it was Custodius in 1949 who first performed scleral buckling surgery for regmatoretinal enjambment. It was later in the 1970s that Dr. McNamara performed vitrectomy, and the internal debate of vitrectomy versus scleral buckling has since then been going on. So the question that needs to be asked, is there a decline in the use of scleral buckling for retinal attachment? If so, then possibly why? Is it possible because it requires significant skill and practice? Is it because it requires a higher learning curve? Or does it require exposure of multitudes of cases and multiple opinions from experts? Or is it because the post-operative complications may be more in buckle, as in case of post-op induced myopia, diplopia, or pain, etc.? All that said, the surgeon should offer the procedure that is the most likely to repair the RD in a single session with the least complications and with the best chance that a second operation will be successful should the first fail. Having said this, there are many certain time-tested scenarios in which both buckling and vitrectomy have analytical and visual outcomes that are comparable. The presentation will be discussed under the following headings. First is case selection. The question to do or not to do scleral buckling in any case is the deciding factor for the outcome of the case. These are some of the indications in which buckle has a favorable outcome: a fresh RD with early PVR, breaks that are depressible and with relatively anterior or not too much posterior locations, retinal dialysis, media clarity, shifting fluid and systemic parameters also play an important role, and there are many instances in which SB is used as an adjunct to pars plana vitrectomy also. Preoperative planning is one of the most important steps in the success to the surgery. It involves doing an indirect ophthalmoscopy with depression of all the quadrants. All breaks must be localized, the amount of PVR graded, the media clarity assessed, and before going into OT, a drawing of the configuration of the RD with the breaks and a proposed plan of management of what segmental buckle, whether the presence of a belt buckle, and how many sutures and proposed site of drainage should be kept in mind. Moving on to the steps of the surgery, even till date some people use extraction sutures to give good exposure on the lids, and in case of tight orbits, lateral canthotomy is performed. Hemostasis should be achieved prior to it. Conjunctival peritomy being the next step, is the limbal peritomy is the most common and preferred. I prefer to place diagonal incisions and not at the 180 and 90, because at least the diagonal incisions come under the lid. And possible complications which can occur are conjunctival buttonholing, which should be avoided by grasping tendons and conjunctiva together. And by combining the radial relaxing incisions, conjunctival tearing and shortening may be avoided. And to avoid exposure to the suture, posterior relaxing incisions should be performed. There are selected cases, example in cases which have already undergone trabeculectomy, in which the posterior incisions, that is 5 to 6 mm from the limbus, is also done. The next step is muscle tagging, and the possible problems which can be encountered with this step are partial tagging, injury to the vortex vein, and injury to muscle belly and tendon. To avoid all this, do good quadrant clearance, isolate the major blood vessels at the margin of the muscle belly so that the entire muscle width is located, and while tagging, always remain anterior to the equator to avoid the vortex veins. Preferably tag the inferior recti or the lateral recti first, and then last should be the superior rectus from lateral to medial to avoid the tagging the superior oblique. After tagging all the muscles in all 4 quadrants, inspect all the 4 quadrants for ectasias, staphylomas, thinnings and dehiscence in each quadrant, because even at this point, if there is too much dehiscence, it may not be possible to proceed with buckling and vitrectomy may be required. The most important step for success of this buckling surgery is localizing the break, and prerequisites to successful localization include good media clarity, pupillary dilatation, and a fundus chart in which all the retinal vessels and retinal lesions have been traced out. Always use a closed tooth forceps or an O'Connor localizer. Indent with the tip of the instrument and not the shaft, and start from anterior and proceed posteriorly. While indenting, ask your assistant to steady the globe and mark with a cautery or marker pen after localization. Always keep in mind link-offs rules when it's not possible to have visualized the break preoperatively, because interoperatively may help you to localize the area of the break. In case of multiple breaks, localization should be done in the form of marking the posterior extent of the posteriormost break and circumferentially edges of extreme breaks. Small holes or tears, it's sufficient to mark only the posterior edge, but large holes and flaps, mark on posterior alveolar anterior extent also. In case of dialysis, mark circumferentially at the edges anteriorly, and then the posterior edge is marked. Avoid parallax effect in bullous retinas, as the retina tends to appear more posterior. Some clues which may help you are pigment epithelial changes in the choroid where the proposed possible site of the break should be, or employ the DAC technique also. In case of cryopexy, the next step after localization, it is to produce chorioretinal adhesions, protect the skin and the conjunctiva while performing cryopexy, and always visualize the tip and indent with the tip and start anteriorly. Do contiguous spots with gentle whitening that should give you good chorioretinal adhesions. Do not refreeze over the same area. Do not apply your cryo posteriorly or blindly. Do not freeze over bare RPA because that may cause more PVR changes or more media haze, and do not apply it to an area of proposed possible site of drainage. After doing cryo, there should be a measurement of the distance of the break from the ora, and hence the buckling implant should be chose. You have both explants and implants, and they are further classified as asymmetric and symmetric for sponges and encircling bands. The general indications for using a segmental buckle are multiple breaks in 1 to 2 quadrants, or anterior breaks or dialysis, whereas radial buckles are used in large horseshoe tears or posterior breaks. Always remember while choosing the number of the buckle that the width of the radial buckle will depend on the width of the tear, and its length depends on the length of the tear, and conversely for the width of the segmental buckle will depend on the distance of the tear from the ora, and the length of the buckle will depend on the width of the tear. To produce a desirable buckle effect, it should be 30 degrees on either side of the break and anteriorly to support ora and posterior margin of break. For example, if you have a break which is 5 millimeters from the ora, then choose a buckle which will have a 7 millimeter size and place your sutures at 9 millimeters from the ora. Coming to scleral suturing, generally partial thickness sutures are used. It should be about 2/3 depth, placed 3 to 5 millimeters long and parallel to the long axis of the tire. We generally use 5-0 polyester, but polyamide has also been used. And while performing scleral suturing, always visualize the needle tip, start from the center of the quadrant, and then proceed towards the muscles. Posterior suture should be 3 to 5 millimeters, and try to indent with the curve of the needle so that you're able to do the bobbing technique and pass the suture along on the sclera. Always avoid posterior pressures and always keep visualizing the tip of the needle. Sometimes too much of posterior pressure can also cause bending of the needle, so avoid that also. Finally, the suture should end near the muscle insertions, and after doing this, give a temporary knot. And the next step should be to place the buckle underneath the sutures and give a temporary knot, and then proceed to do an indirect ophthalmoscopy to see whether the break is flat on the buckle and whether the need for drainage is there or not. If there is no need for drainage, then do finalization of your sutures past your belt buckle, and then you can close the conjunctiva. But if there is need for the drainage, then you need to move the buckle aside from the site of the drainage and then do drainage. Indication for SRF drainage are some of the following conditions: bullous RDs, PVR more than grade B, inferior breaks, aphakics and pseudophakics, high myopia, glaucoma, poor RPE function, and chronic RDs. The principle of SRF drainage involves elevation of the buckle by diminishing intraocular volume. Hence, the retina will settle on the buckle and facilitate closure of the break. To do good drainage, always avoid areas of choroidal vessels and vortex veins. Preferably do above or below the horizontal meridians, and preferably in the posterior 1/3 of the buckle. If it's not possible to do under the buckle, then use a mattress suture and be ready to close the sclerotomy as soon as the drainage is over. Always avoid sites near retinal breaks or cryo marks. You can either use a 27 gauge needle to do direct drainage, or use a 10-0 suture needle after doing a choroidal knuckle. Always use cautery to the edges of sclerotomy so that the sclerotomy edges retract and the choroidal knuckle becomes more pronounced. And as soon as drainage is done, please put the buckle over the area of drainage and finalize your sutures. Always monitor IOP constantly during drainage. It can be substituted later with doing intraretinal gas injection or saline. And any fall in IOP while draining should be compensated with traction of with not much traction of the muscles, but using cotton tip applicators placed 180 degrees away from the site of drainage. After the drainage is done, then the traction of the suture should be increased. In case of repeat drainage, you can try it through the original site or second site after doing a repeat indirect ophthalmoscopy. Possible complications in drainage are dry tap, retinal incarcerations and retinal perforations and choroidal hemorrhage. Ultimately, the key to a good scleral buccal surgery is good localization and treatment, selection and placement of a buccal, and doing uncomplicated SRF drainage. Thank you.
Thanks, Dr. Bragadish. We'll have the discussion at the end. Now I call upon Dr. Sriram Gopal. So, he's a vitreoretinal surgeon at Trichy, and he will be speaking to us on symptoms and rhegmatogenous retinal detachment.
Good morning, dear friends. Okay. Slide advance इसमें नहीं है. ठीक है, इस लैपटॉप में करेंगे. No problem. Good morning, dear friends. Here to tell you a few tips on how to maximize your outcomes in rhegmatogenous retinal detachments. We all heard Bragadish. Why do you need to do a vitrectomy? Well, you have a much better view of the retinal periphery, and you can easily identify the retinal breaks. You can achieve a complete intraoperative retinal reattachment, and it is free of all the risks which Bragadish just mentioned. And given the fact that most of our retinal detachment these days are pseudophakic eyes, and the patients don't usually like to have a myopic shift, these vitrectomies are much less likely to cause a refractive change. And with smaller gauge systems, the convalescence and the recovery of the patient is much quicker compared to a scleral buccal. Start off with a disclaimer. This is not really a teaching session. I'm not here to establish any practice pattern. I'm just trying to hand over tips which I've thought and heard over the years, and the lessons which I've acquired through burning my fingers. So what are the objectives when you do a vitrectomy for a retinal detachment? First is removal of the vitreous gel as much and as safely as possible, and any pre-retinal traction, intraoperative flattening and attachment of the detached retina, applying retinopexy, be it laser or cryo, and placing a tamponade inside the eye. These are about steps of a vitrectomy, like you can choose your encerclage if you wish to place one, what gauge you'd be using, how you'd place your ports, etc. We'll try to cover most of these things. Choice of gauge, smaller gauge vitrectomy systems have a good advantage. The 23 gauge system is very stable. The intraocular environment is much more stable than a 20 gauge. 25 is even better, but the 25 gauge is much less rigid, which doesn't let you rather approach the periphery with that much ease. A 20 gauge is very rigid but needs a peritomy, and I would say that overall, if you look at it, a 23 gauge valve cannula is the best bet for a rhegmatogenous RD because there's very good stability. There is no leakage from your cannulas, so there's no risk of vitreous or retinal incarceration. And at the end of surgery, closure is quick and easy. You can either leave it sutureless, or if you think there is a slight leakage of your gas or whatever you put in, all you need to do is pass a single through and through suture which goes through the conjunctiva and sclera at a time. Placing the ports, I would lay maximum emphasis on this step in a rhegmatogenous retinal detachment. You should ideally locate sclerotomies in any vitrectomy to avoid conjunctival scars or filtering blebs. But it is more important to place your sclerotomies so that they allow the greatest degree of intraocular access. So if you look at the pointer. So if you look at the diagram here, you realize the active sclerotomies are almost at the horizontal meridian. Actually, this diagram depicts it even below the horizontal meridian. So I'd prefer placing my sclerotomies just above horizontal meridian and then placing the infusion cannula below. I would say almost at 170 degrees. Why? See, this is a phakic patient. You can see my cutter coming from almost the 9 o'clock position in the right eye, and I'm able to almost access up till 4 o'clock, go cut peripheral vitreous as much as possible. There'll be a small area between 2 o'clock and 4 o'clock which you cannot access from this side, which you can always change hands. So you can literally go around the posterior curvature of the lens and then approach the peripheral vitreous. And not only vitrectomy, Even during endolaser, this is again a phakic patient. Sorry, it's playing up. Yeah. So phakic patient, it's a curved endolaser probe. I flattened the retina, posterior retina, the heavy liquid. I'm doing laser to the periphery, 360-degree laser, as close to the aura as possible. So this is pretty much possible in a phakic patient without encirclage or indentation. This is because I've placed my ports in such a way. And initial vitrectomy, when you start vitrectomy, try to clear your ports as much as possible initially. Don't be in a hurry to go near the disc or go near the break. Make sure your sclerotomy ports are clear. So this would help clear the vitreous from the port so that in case you have to pull out of the eye, you don't pull on any vitreous and create a incarceration there. Next is clear the traction near the break. We will see in the next video. And I initially tend to flatten the retina to a certain extent with a fluid exchange so the retina doesn't keep jumping and flapping up. And at all times, in any vitrectomy, and especially when you have a retinal detachment, visualize your cutter port, never lose sight of the port. And when you have a small vitreous, when you cover the central core and you have a small vitreous skirt hanging, approach from the posterior edge of the port. That helps you save time and make your vitrectomy more efficient. So this is a video. I have cleared the central core and now you can see I am coming to the periphery. There is a small break with a flap there. I usually clear the vitreous around the flap and then cut off the flap. This hole is a little too small for me for easy endo drainage because once you start FGE, your view is not that great. You might tend to incarcerate the retina in your cutter or your flute port. So I usually tend to clear the vitreous, enlarge the break to a comfortable extent, not too big though, so that I don't end up incarcerating the edges of the retina. And then now I'm doing a fluid exchange. You'll slowly see all the subretinal precipitates coming through the subretinal space into the cutter, as you can see here. So settle the retina to a certain extent. At this stage, if you want, you can just put a small bubble of heavy liquid, a cc or so, or 1.5 cc, to stabilize the retina and then continue with your remaining vitrectomy. So peripheral vitrectomy, well, peripheral vitrectomy or base excision, it's not one and the same. It is not indicated in all cases, point one, and it is easier said than done. And if you are going to do a base excision, it is something you need to be very aggressive about. Usually reserve it for very extreme cases of PVR. It is just not possible in phakics, quite difficult in pseudophakics, and if at all, it is only possible only in a aphakic patient. If you have a good assistant or a good encirclage, you place a good encirclage, it makes your peripheral vitrectomy much easier. And when you're doing a peripheral vitrectomy, be very thorough. With new gauge systems and high vitrectomy cut rates, it's almost possible to literally shave the vitreous off the retina. And you need to be very thorough, but yet be very safe with it so that you don't create additional breaks. So this is a video where my assistant is indenting. I'm lucky enough to have a decent assistant, so you can see you should use something like a muscle hook or a vectis so that you get a flat, broad indent like this. A pointed indent is not that good. You can visualize the aura here, the infusion cannula. So you can almost come close. I have stabilized the posterior retina with heavy liquid so it doesn't jump up. And this is another novel way which I found out. You can use a chandelier. There are chandelier systems which fit into your 23 gauge trocar. So I fit one such chandelier into my 23 gauge trocar. I have removed my light pipe. I fit the chandelier here. My left hand is now free, so I am indenting with my left hand and I'm using my right hand to cut. If you think your assistant is not good, you can invest a little bit in this chandelier system and you can have the comfort of indenting yourself while doing the vitrectomy. Not that easy in phakics, but pseudophakics, yes, very much possible. Use of heavy liquid, well, it's got its obvious advantages. You can use it very well to stabilize the retina, pop in a little bit in the initial vitrectomy once you clear the core, as 1 or 1.5 cc to stabilize the retina. It prevents the retina from fluttering, it will prevent incarceration, you can get much closer to the retina and the periphery. The drawbacks would be if your break is relatively posterior and you inject heavy liquid a little prematurely, you can make the fluid get caught anteriorly, and there are some times when initially you tend to inject heavy liquid at a time, 3 cc, 4 cc into the eye, you've not done a thorough vitrectomy in the periphery. The vitreous skirt can get caught under the heavy liquid, you will not know it, and once you remove the heavy liquid you realize you left so much vitreous in the periphery. This is again heavy liquid. You can see my assistant indenting there. So I have stabilized the retina anteriorly is hardly jumping up. I'm almost going close to the retina, hardly leaving any vitreous in the periphery. You can see there's a very slight shudder of the retina, that's it. The other way you can do is you can visualize the vitreous, you can use intravitreal kinolog. I prefer to dilute it before I inject. I usually take 0.1 to 0.2 cc, dilute it to half cc. That gives me a much even spread and a much even stain, as you see here. And endocautery, remember, a cautery is to identify the break during FG. It doesn't help anyway in reattachment of retina. It actually necrosizes, the retina becomes necrotic, so it doesn't stick easily. So just make a small burn so that you can see the edge of the break, and that's it. There's no need to go all around the break and cauterize all the edges of the break. It is just to identify the edge of the break, that's it. So settling the retina, once you've done a good vitrectomy, you cauterize the breaks, you identified all the breaks, you mark them. We have a few options. One is a direct FG. Well, if the breaks are at the equator or posterior, a direct FG is the easiest thing to do. You don't waste any heavy liquid. If your breaks are very anterior, you can use heavy liquid, and also breaks which are not easily accessible to an FG directly, you can use heavy liquid. Or if your view is not good, say because of some lens opacity or there's a very complicated anterior segment surgery, the IOL reflexes are too disturbing, then you can use heavy liquid. You can prefer to do a drainage retinotomy alternative to a PFCL, but I am not too much in favor of creating an extra hole in the retina when already the retina has got multiple holes. And I'd prefer to combine heavy liquid and fluid gas exchange. I initially put 1 to 2 cc of heavy liquid, flatten posterior retina. I usually fill heavy liquid only up to the posterior margin of the break. Finish the posterior laser, as you can see. If possible, even rotate the eye and finish the laser as anterior as possible. Start FG. If you see here, this is the heavy liquid margin. There is up to the posterior anterior margin of the break, and then the air bubble keeps going back. I place my cutter port there. It's important not to move your light pipe too much, even if you transiently lose view, as in this situation. After a couple of seconds, the view will clear up as the air bubble goes posterior to the edge of the light pipe. There's a lot of glare when it crosses the light pipe. These are few lens opacities which are disturbing. Now I've cleared up to the break. Whatever fluid was anterior to the heavy liquid has now come off. Now probably all the heavy liquid inside the vitreous is coming. And a key, what indicates that you've done this properly, is once you've finished, you see a well-attached retina and there's hardly any fluid left at the disc. There's just a little bit of heavy liquid. I'll usually swap my cutter for a flute after this, because I have an end-on aspiration, and go and remove whatever little heavy liquid is left behind. You can have a few problems during, sorry for the spelling mistake. Can have a few problems during fluid gas exchange. If you have an open PC, you can have a condensation on the intraocular lens. And aphakic FG, the whole anterior chamber becomes flat. There's a small air bubble caught in the pupillary area, and your view is not great. Well, there are easy ways to overcome it. Here we see pseudophakic eye, open PC, condensation on the intraocular lens. Simplest solution is coat the posterior surface of the IOL with HPMC. Because I'm using a smaller gauge system, using a 27 gauge cannula, don't inject, just give enough to put a gentle coating, otherwise that itself disturbs your view, and this should hold for at least next 10 to 15 minutes. If you want, you can redo it. Aphakic FG, always start the FG from the anterior chamber angle. It's a very good tip, because once you start, you get rid of all the aqueous in the anterior chamber, and your air bubble completely fills the anterior chamber like this. Anterior chamber deepens, your view becomes very, very good, and whichever way you move the eye, your view doesn't get distorted or disturbed. Retinopexy, well, the two common options we have is either endolaser or cryo. I prefer endolaser for most of my patients, but especially for posterior lesions. Extensive lesions, I'm not a fan of cryo. And you need to be contiguous, as in this photograph. With endolaser, unlike a PRP where you'd leave a few gaps. I'd reserve cryotherapy for very anterior lesions. Phakic patients where I fear a lens touch because for my endolaser probe and the break is very difficultly placed. Usually if it's a small break, I would prefer a cryo, because there's less RPA exposed and there's less RP going to fall into the vitreous cavity, and I would like to limit my cryo to as few burns as possible. A lot of times I would prefer doing endolaser as much as possible, and if I cannot do endolaser to one particular area, I would just do 2 cryo burns to that area alone. Here you see patient with Regardi, retina settled with heavy liquid, endolaser on the belt buckle, contiguous burns. If I'm going to do a 360 degree laser, I usually opt to put at least 2 to 3 rows, contiguous. Usually you know where the posterior edge of the vitreous base is. You know the vitreous is detached up to that extent. That is where the patient is likely to get further breaks in future. So make sure your endolaser burns are there and not at the equator or posterior, where it is usually much easier to do, but it doesn't really help in any way. Choice of tamponade, lot of studies about leaving air in the vitreous cavity. Well, I don't have that much guts to do that at the moment. But I usually swap between SF6, C3F8 and silicone oil. I have a simple rule of the thumb. If any fresh RD, I always use gas. And if the break is above horizontal meridian, I use SF6. Below horizontal meridian, C3F8. And special situations like RD with PVR, GRT, and 1/8 patients, because if you use gas, he's going to be literally blind for the next few weeks. I prefer to use silicone oil. Heavy silicone oil, very good for inferior breaks, but I don't really have much personal experience in that. Just going to go through a couple of videos for want of time in special situations. RD with PVR, use stains, use trypan blue to stain the epiretinal membranes, as in this case. You can use a pick or barb a 23 or a 20 gauge needle and use it, but newer vitrectomy forceps, they are pretty sharp enough, so you can directly go and pick the membrane. Always go from the disc towards the aura so that you don't there is no risk of forming a tear because of your traction in the retina. And peeling in macular hole, you can do it in two ways. You can do it under heavy liquid. This one actually demonstrating doing it under fluid. I usually do a small fluid, settle the retina to a certain extent. And here again the tip is to go from the disc, keep going temporarily. Normal macular hole you will tend to catch there and pull here. Don't do that because you risk elevating the retina. You always go from the disc temporarily. If you do a fluid and then start this, your retina always stays relatively flat until you finish it. Thank you.
Thank you, Dr. Sriram.
Next, I would like to call on Dr. Kausthanathan to talk on simple steps to maximize the outcome in macular hole surgery.
Okay, I'm going to discuss about the basic steps and small tricks to maximize outcomes in diabetic vitrectomy. Coming to diabetic vitrectomy, the basic steps would be PVD induction and truncation of cone, removal of the vitreous and subhyaloid hemorrhage, dissection of the water membranes are there, do a good laser photocoagulation, and whether to use a tamponade or not. But most of the times it's not as simple as these 5 steps. The traditional indications of vitrectomy being a non-clearing vitreous hemorrhage, a tractional RD or a combined RD. Now, even before we move on to the actual vitrectomy, there are some pre-op considerations which one needs to be aware of. The 3 most important, I have put it on here. The first thing is a good B scan. What the B scan would do is it's going to identify the areas of PVD for us and to help us know where we have to enter the posterior hyaloid. It also tells us if there is any macular traction, which helps us to prognosticate and discuss with the patient pre-op. Now, if we get to do a B scan and we see a picture like this, so this is a very good sign for a surgeon. You can see a lot of subhyaloid hemorrhage here with the PVD there, which means this surgery is going to be pretty easy. Now, if you're going to have this kind of macular traction, now you can see here where the PVD is pulling on the macula there, and the macula is pulled up. Now we know that there is some membrane surgery needs to be done, and the prognosis is not going to be very great. The second thing is, most of the times the thick posterior hyaloid or vitreomacular traction cannot be picked up very easily on the clinical examination in terms of minimal vitreous hemorrhage or a hazy view. And it's not a bad idea to get an OCT done pre-op when the clinical macular picture is not corresponding to the vision. So it helps us to know that whether we have to peel the ERM or the ILM if it's there. This is just another picture to show the presence. If you see the fundus picture looks very innocuous, but when you do the OCT, you see a large area of attached posterior hyaloid. Now, the other thing which is very important is to do a good pre-op laser photocoagulation, which is very important, especially for the medical retina specialists as well. Now, what this does is it quietens the disease process for us, number 1. It decreases the tendency to have intraoperative bleeding, so surgery becomes more easy. And what the other most important thing the laser does as far as vitreoretinal surgery is concerned is it induces some amount of sterile inflammation inside the eye, and this helps to induce the PVD. What is most important in people who do pre-op laser for diabetic retinopathy is you should never hammer the retina with laser. Most of the medical retina specialists sometimes keep doing more and more laser. But what this does is instead of inducing sterile inflammation inside the eye, it literally nails the PVD to the retina. And even if the PVD were to happen later, what happens is you tend to have small tiny breaks from the laser scars, or even when we were inducing PVD at the time of surgery, you can have multiple small breaks which we might miss out notice. The other thing is you should always do laser away from the polyps, stay away from them at least 2 to 3 disc diameters. Now I'm just going to talk about PVD induction in a diabetic now. The first most simplest of scenarios would be when you have done a B scan, you literally can't see any of the retina pre-op. You've done a B scan and there is PVD all around 360 degrees. You go into the eye, and when there's a lot of subhyaloid heme present, it's a very nice thing to have. You might have a little PVD attached to the disc or not. Now what is most important here is, once we open the posterior hyaloid, it's a good thing to remove all the subhyaloid heme from the subhyaloid space, because there might be some areas where the retina might be attached and the peripheral TRDs might be present. I'm just going to show you a small video wherein you see there's totally no view of the retina to start with. Once you clear the hemorrhage completely, slowly you start getting a good view of the retina, and there is no obvious traction, and this is one of the simplest surgeries that you can do in a diabetic. The next scenario would be a little bit more complicated when I bring in the concept of what is called as membrane surgery, when there is a PVD in a few clock hours, but there is no PVD in the other areas because of traction retinal detachment. Now it is this condition where the pre-op B scan is probably very, very crucial. It helps you tell where you have to enter the subhyaloid space. Once you enter the subhyaloid space from that area, then you can work circumferentially from where the PVD is present to areas where PVD is not present. Now how do you induce the PVD? You can probably use the cutter. You can probably use, I'm just going to show a small video wherein using a cutter is being used, 23 gauge cutter is being used here to grasp the edge of the PVD, and then you induce it for a couple of clock hours and then cut the PVD. You cannot keep on pulling on the cutter because you can have breaks either at the periphery or at the area of maximum traction. The last scenario would be when you have no PVD at all pre-op. You can see most of the retina, there's a total fat polyp. This is where clinical examination is very important. We need to look for areas where polyp is elevated or can be elevated with a visible cleavage plane. If it is quite an avascular polyp, then we can use a 23 gauge forceps to just grasp the polyp at the disc and yank it a little bit till you get a plane of dissection. Now what is most important when you have do membrane surgery is you have to dissect the correct plane, and it's not really mandatory to get rid of all the polyps completely. As long as we remove, as long as we can segment most of the polyps and there's no residual vitreal retinal traction any of the polyps, then that's fine. Now coming to membrane surgery, the most important steps would be identifying the proper plane, using the right instrument, and stopping at the right time is very important. And if necessary, never hesitate to do a bimanual surgery. Now, what are the problems that one can encounter at the time of membrane dissection? There are only two things one can happen. One, you can have a bleed. The other thing, you can have a break. Now, how to avoid this is, the most important thing is to expect the complication all times. Both of these things can happen at any point of time when you're dissecting. How to avoid is, if you start dissecting the right plane, usually prevents a bleed, and to especially avoid dissection where the polyp is thick and underlying retina is fragile, it's better to dissect in an area where the polyp is thin and underlying retina is quite strong. And it's always good to start from the center to peripheral, because we all know the central retina is more thick than the peripheral retina. As I said, one can use either a 23 gauge needle or an MVR blade. You have to identify the correct plane of dissection, and you can look for vascular nails wherein the polyp is more densely adherent, and one can use a scissors or even the cutter. You can also do what is called as a proportional reflex or a visco dissection to identify areas of vascular attachment. And the most important thing of membrane dissection is don't miss the second membrane. It is usually a small thin fibrous tissue which is extending anterior to the edge of the existing polyp that is seen visibly. Once you start lifting the edge of the membrane, you can actually see the second membrane, and can then go to the second membrane. Sometimes if you can't see it clinically, what you can do is you can put in a drop of IVTA or a dye to identify the second membrane, and that will help you to recognize that. Now I'm just showing a small video where little dissection is being done with the scissors. The vascular epicenters are identified, and once the scissors is introduced into the cleavage, you just push the polyp a little bit and then cut underneath. Now what happens when one encounters an iatrotic break during dissection is, now dissection it can happen because of traction, can be caused by bad scissors or a bad technique. Now, once you have a dissection, most important thing I would suggest is one has to cauterize, because it's very easy, because the surgery might be about 2 to 2.5 hours. One can lose a site, one can forget that you had a small break elsewhere. The first thing is you have a break, it's better to cauterize it. And once you have a break, we are committed to relieve all the traction around the break. Now, coming to the next important thing is probably the most frustrating aspect of diabetic retinectomy is to have a bleed. Now, this usually happens when you start dissecting in the wrong plane, and it can happen because when we cut into the vascular nail, it can happen from cut into the fronds or the edge of the arterial breaks. Now, how to avoid? First thing is, it's a good thing to have a good control of systemic risk factors, find out the patient is on pre-op blood thinners and try to avoid them if possible. And avoid over dissection after we segment. Once we segmented and there's no residual traction on the segment, then we can just leave it alone. The first thing is what we tend to do is you can elevate the intraocular pressure, and if that doesn't work, one can put in a small bubble of PFCL over the area of bleed. And once you put in a bubble of PFCL, then probably you can leave that area and start working the other areas, and by the time you come back to that area has stopped bleeding. The other thing we can do is we can do an air fluid exchange to arrest the bleed there, and while the air is inside, one can complete the laser in the periphery where we already finished the vitrectomy, and cauterize the tip of the bleeders. It's not moving. Okay, it's not moving. Yeah. Okay, basically when you have a bleed, there can be two types of bleeders. One is you have a small ooze from the surface for which you can use endolaser. Other thing is when you have a bleeder from the cut end of a frond or a polyp, one can use a cautery. Once you have a clot, what you should do is you should never try to remove the clot, dislodge the clot immediately, because that can cause more bleed. Leave the clot there, work in other areas, come back and then trim the clot and leave the small plug of the clot behind. And when you're using a cautery, you always move towards the bleeder. So don't directly go to the retina. When you start going towards the bleeder, what it can do? And give a small burst. It can disperse the heme from the area where it's bleeding, and then you can cauterize. The very important tip is you should always make sure the cautery works before you start surgery, because many times when we ask the sister for a cautery and you find the cautery doesn't work, the sister has to go and get another cautery by the time you have a big clot on the retina. The other thing is avoid cautery too close to the disc or to the major vessels. Now, cutter has literally pushed out scissors and forceps out of the diabetic retinopathy surgery. It's a multitasking tool. It can help you work like a flute. It can help you induce circumferential PVD induction. It helps you segment. Sometimes it acts as vertical scissors when you use in a single cut mode. You can very importantly use it what is called as carpet rolling maneuver. It can also be done to use the proportional reflex. Now, coming to laser photocoagulation is probably a very important thing. One needs to do quite an aggressive drop laser photocoagulation, even if sometimes the diabetic retinopathy looks quite innocuous, because it helps to decrease have a tendency of post-op wet bleed, and it takes care of small peripheral NVEs which we can miss clinically. Now, whether we have to use gas or oil, when the surgery is pretty straightforward, simple, you've not had a break, one can leave the eye with air as well. Now, when you have a long-standing tractional RD or a combined attachment, or when one anticipates to have a post-op with hemorrhage, it's better to use silicone oil. And when you have difficult surgery with prolonged breaks or a grossly ischemic retina, or if the patient has to travel early, has to have an air travel, or if you dealing with a patient with a PDR with rubiosis, it's always better to use oil. Now, the combined retinal attachment is a totally different entity. It's a very interesting challenge for an EVR surgeon. The problem here is the underlying retina is mobile, and when you're peeling, there's no counter traction. One can use a small bubble of PFCL to stabilize the posterior pole, and what you can do is you can actually start surgery in areas of attached retina and then come to the areas of detached retina. Complete relief of traction around the break is mandatory, and never hesitate to use bimanual surgery when you're dealing with a combined RD. Most important thing is when you have a combined RD, sometimes the fluid under the SRF in a combined RD is very thick, and once you open up the FG, it doesn't come out of the subretinal space. So what we can do is you can do what is called the fluid-fluid exchange before you proceed on to the FG. Just to show a small video of combined retinal attachment here, clearing the vitreous hemorrhage there. You can see the underlying retina is mobile. So peeling becomes a little bit more difficult in a combined RD. One can use a grasp with the forceps, always looking for peripheral breaks or breaks at the site of maximum traction. This is probably one of the very important things that I want to discuss is it's never more frustrating than to have an early post-op with bleed. A patient keeps complaining and cribbing that he's not seeing anything. There are ways to probably reduce the incidence, but it cannot be completely eliminated, the incidence being almost up to 30%. What one should do to avoid post-op with him is to reduce any residual vitreoretinal retraction by using IVT at the end of surgery. And most of the time we work in an IOP of 25 to 30. It's always a good thing to come back to 15 to 20 at the end of surgery and see the bleeding areas. You take care of them even before you close. Do a good scleral indentation and remove the blood clots in the periphery. An aggressive PRP goes a long way. Even if you have an early post-op with bleed, it clears it faster. If you do an aggressive PRP, one can probably think about doing cryotosclerotomy sites, especially when you're dealing in a vitreous lavage case, and a tamponade also help. Now, one last slide about the role of pre-op Avastin. Pre-op Avastin is always advisable when you're dealing with a vascular prolif. Give it within a week. It improves outcomes and it actually facilitates surgery. There is less intra-op bleeding and less incidence of post-op with heme. What one should do is always, timing of injection is very crucial, and get the fitness for surgery and then inject. Many of these patients have comorbidities which will postpone surgery and will be in a mess. The other thing is, as I said earlier, it's easy to miss diabetic macular retraction, diabetic macular edema. So once you've done a good laser, somebody has done a good laser, vision not accounting for that. There's no role for medical management in a tractional diabetic macular edema. One needs to do an OCT and look for, there's the possibility of having a vitreomacular traction or a taut posterior hyaloid, and sometimes you can have an epiretinal membrane because of aggressive laser. Showing a small video about, there's a small membrane which is extending from the disc over the macula which is being peeled, the spatula nicely. So this is very important, and because if you want this membrane is not removed, then the visual outcome is not going to be good. Though somebody always have a surgical plan when you're dealing with the proliferative diabetic retinopathy, PVD injection is probably the most important and the most difficult step. Once you have a good PVD, most of the job is done. Never hesitate to use IVTA for your first 100 diabetic vitrectomies or even later. The art of membrane surgery is always challenging, and nothing like practice. Always share and discuss your intra-op issues with your colleagues and teachers. And the very important thing is, don't let a bad case affect your heart. You've got to move on. Thank you for listening.
Thanks, Dr. Ramana. Now I call upon Dr. Vishwanathan to speak to us on simple tips for management of nucleus drops. Meantime, I would request Dr. Manoj to get his presentation ready.
Good morning, everybody. I'm going to talk about simple tips to maximize the outcome during the surgical management of dropped nucleus. If you want to propagate your VR surgical skills to your anterior segment surgeons in your locality, then this is the marketing tool. You can also become very famous if you do it free of cost. The first and foremost is the pre-operative preparation. Please don't yield for the anterior segment surgeon pressure to take up the nucleus drop case surgeries immediately if you are committed elsewhere. Just reassure them that it is not a medical emergency, that it needs to be operated immediately, and the nucleus drop cases could wait for a few days if it needs to be. Tell them to give acetazolamide up to 1 gram per day in divided doses, which helps to reduce the intraocular pressure and also reduce the corneal edema, and you can examine the fundus clearly when you see the patient before post-op. The usual antibiotic preoperative drops can be given up to 6 times a day, and also advise them to give some dilating drops so that the pupil is well dilated when you see the patient before the surgery. And before surgery, while examining the patient, please assess the intactness of the capsule so that you can decide whether the capsule is there for sulcus IOL or you have to put scleral fixated IOL. Or examine the nature of the nucleus to assess the size and the consistency to decide whether you can use the cutter or you need a fragment hole. and also examine the retina if the media permits you to see if there is any retinal tear, as it is not uncommon to have retinal tear as they try to fix the dropping nucleus with phaco probe or wet test. And do not promise both the referring consultant and the patients that all will be done in one surgery. We all know how to respect the retina, but also please take care of conjunctiva while doing vitrectomies to have a good post-operative outcome. Remember, the conjunctiva and the tenon share the common attachment in the sclera anteriorly close to the limbus. So it is always better to start your conjunctival dissection there. Conjunctival peritomy is done by careful dissection of both conjunctiva and sclera, and bear in mind that conjunctiva can tear off, especially in elderly, or if it is grasped too close to the limbus or with a tooth forceps. So please do not use tooth forceps and avoid lower conjunctival blood vessels to avoid subconjunctival hemorrhage post-operatively. Please know your gauge before doing peritomy, as the size of the gauge dictates the amount of the peritomy. For example, if you are doing 20 gauge vitrectomy, then you have to do a reasonable amount of peritomy both temporally and nasally to expose sufficient sclera to make the 20 gauge scleral ports, sclerostomies. And also you can use this exposed sclera to make the scleral tunnel. But if you are using 23 gauge, all 23 gauge vitrectomy, then you don't need any peritomy, as the sclerostomies are small and self-sealing. But if you are using both 23 gauge and 20 gauge vitrectomy, like in this patient, it is sufficient to make a very localized peritomy over the sclera where you are going to make a 20 gauge sclerostomy to use either vitrector or the fragment hole. And it is also advisable to put a corneal stricture over the corneal wound, even if the corneal wound appears self-sealing, especially if the sclerostomy is in line with the corneal wound. Plan your IOL and the incision type before sclerostomies. If you decide to put a 3-piece intraocular lens in the sulcus, then you can use the old corneal wound created by the cataract surgeon and place the lens, and there is no need to extend the corneal wound. While putting the intraocular lens, make sure that you use sufficient amount of viscoelastic to protect the cornea, which is already compromised by the previous difficult cataract surgery. But for various reasons, if you decide to place a non-foldable single-piece IOL, it is always better to use scleral tunnel rather than making large corneal incision. And making scleral tunnel, it is always better to make it before making sclerostomy, as the eye will become very soft, and it's very tricky to make sclerostomy, scleral tunnel after sclerostomy. So after making the scleral tunnel incision, 20 gauge sclerostomy is made. Once the vitrectomy and the nucleus is removed, you can place a single piece non-foldable IOL in the sulcus through the sclerostomy wound, but make sure that you close the port with the scleral plaques and also close the infusion port to avoid the aggressive fluid through the scleral tunnel. In this patient, 23 gauge vitrectomy was completed and the whole nucleus was removed, but for various reasons he had decided to implant a single piece IOL in the sulcus. For that reason, we had to extend the corneal wound, and finally the corneal wound needed to be stitched. This could have been avoided if it was planned initially and if you had done a scleral tunnel incision. So it is always better to avoid the multiple corneal stitches for obvious reasons. And if you put a sulcus IOL, it is always better to use a 3-piece IOL in the sulcus rather than putting a single piece IOL in the sulcus. Well, during the vitrectomy, before diving into the deep vitreous, please do anterior vitrectomy thoroughly. It helps to clear the media and it makes it more convenient to see the core vitreous and the retina before doing nucleus retrieval. So in this patient, both 23 gauge and 20 gauge vitrectomy is used. Initially a thorough anterior vitrectomy is performed, and once the anterior vitrectomy is performed, the soft lens matter is removed with the same cutter probe, but make sure that the cutting mode is off and just aspiration mode is used. Otherwise you will cut the anterior capsule and it will become impossible to place the IOL in the sulcus. So here the soft lens matter is thoroughly removed, and then I decided to remove remaining vitreous from the anterior chamber through the corneal wound. But you have to be very careful while using. You can watch here the iris is caught in the cutter and it is damaged, but thankfully the capsule is intact. So make sure that you don't use cutter very close to the capsule. Then the nucleus retrieval, it is very ideal to use fragmentome than the cutter to remove the nucleus, than to remove the whole nucleus into the anterior chamber. PFCL can also be used to remove nucleus, but the drawback with the PFCL is that the nucleus fragment and the nucleus keeps migrating to the periphery of the PFCL bubble, and you have to constantly bring back the nucleus to the center of the meniscus before cutting. In this case, PFCL is not used, so initially posterior vitreous detachment is created, then the vitrectomy is made and the nucleus is thoroughly relieved of its attachment with the vitreous, and once the nucleus is free, it falls back, then a thorough vitrectomy is performed. Once the vitrectomy is completed, then the fragmentome is used. It could be detrimental to use fragmentome in the absence of complete vitrectomy. So now the vitrectomy is completed and the fragmentome is used. With the fragmentome, grasp the nucleus, bring it to the mid-vitreous cavity and then start emulsify. It's very, very important to make sure that you emulsify only in the mid-vitreous cavity. So repeat the same step multiple times until the whole nucleus is removed. Even the cutter can be used if the dropped nucleus is very small or it is soft. So the finishing touch is the peripheral examination, which is the very basics of any VR surgery. Make sure that after removing the complete vitreous and the complete nucleus, you do a thorough examination to look for any peripheral breaks. The most important part is moving the indenter from anterior to posterior to see the peripheral retinal breaks rather than moving it sideways. And you could see a surprise like this, where you can see a small break. And if you see like that, you will not be able to finish the surgery as you thought. So the key points, the summary is, nucleus drop is not an emergency. Please take care of the conjunctiva. Decide on vitrectomy gauge before peritomy. Decide on IOL type before your sclerostomies. Do not use cutter mode to remove the cortex close to the capsule. Do not use frag before complete vitrectomy. And peripheral examination is a mandatory step in any VR surgery. Thank you.
Thank you, Dr. Vishwanathan. Now we will move to the last talk of the session. We have Dr. Manoj Khatri from Chennai again. He will be speaking to us on simple tips for endophthalmitis.
Very good morning to everyone. I have no financial disclosure. As we all know, the incidence of any intraocular procedure is on the rise, so as well as the incidence of endophthalmitis is also on the rise, and it can be due to various etiologies. The main key point here is when we have a patient with endophthalmitis, before even that, we should always emphasize for prevention, early recognition is the key, and active therapeutics should be involved very judiciously. We should not waste time. Certain post-operative endophthalmitis risk factor which can be avoided, like it have patient's factor, if the patient has any local disease should be treated, intraoperative surgical factors, and as well as surgeon's factors. I am not going to details because of paucity of time. If you look at the clinical presentation, we can either have an acute presentation or acute on chronic or a chronic presentation, and then the treatment involves immediate initiation of intravitreal broad-spectrum antibiotics without wasting any time. You can do it in the OPD. I'll show you how to do it, with or without requirement of a vitreous tab biopsy, or if the patient is not responding to either, an immediate plan of pars plana vitrectomy. The choice of antibiotics will be dealt in detail. How to go about the management? First of all, a detailed clinical examination is a must. We should also emphasize on the necessary investigations as and when required, like ultrasonography. It's very crucial in making the diagnosis and proceeding further. All these tests and the procedures have to be backed by a good microbiological examination of the specimen, and treatment can be medical or surgical. The role of PCR cannot be emphasized less in today's scenario. Every sample intraocular fluid taken from the eye should be sent for microbiological evaluation, which also includes PCR, which can give us a lot of insight into the organisms which we are dealing with. However, when we go for a medical management algorithm, first we start with antibiotics. The common choice is vancomycin and ceftazidime. If we see for the response within a day, if the patient is not responding, then you can go for a repeat injection. If it is still worsening, then we can plan for vitrectomy straight away. In conjunction with alongside, you can have systemic antibiotics, start with local therapy, corticosteroids as well as cycloplegics to give rest to the eye. Intravitreal antibiotics can be used. For gram-positive, we can go for vancomycin, which is a treatment of choice. For gram-negative, we can choose for ceftazidime, and for fungus, we have various antibiotics.
So let's look at the RGP fitting philosophy. The goal here is to provide adequate vision with maximum comfort over a prolonged period of time. The lens, very many lens designs have been proposed and used in the past. They are classified on the basis of the relationship between RGP lenses and the apex of the cone. So let's look at that. Essentially, three broad categories are there of lens designs: the apical bearing, apical clearing, and the three-point touch. I'll be going a little into detail of all of these, but let's clear the terminology. There's a lot of confusion about terminology. Let's clear that up first. What is lens bearing? Lens bearing means essentially lens touch. There's a touch between the cornea and the lens in that particular area. So, as a result, if there is a touch between the cornea and the lens, there would be no tear film in that area interposed between the lens and the cornea. And if there is no tear film, if you put in fluorescein, that area will not take up the stain because there is no tear mixed, fluorescein mixed tear film there. And therefore, the dye will not be visible in that area of touch, and that's called the bearing area. Lens clearance is the area where there is no touch in that area, and because there is no touch between, no contact in the cornea and the RGP lens, tears mixed with fluorescent dye will fill this area, and fluorescence is observed. And base curve refers to the central posterior curve of the lens. So let's look at the three-point touch design. This is the most frequently advocated design for keratoconus. At this point, I'd like to tell you, in RGP fitting, the starting point is the keratometry values. You take the keratometry values either by a manual or even a auto keratoref, and after you got the values, then you decide how to proceed. In a three-point touch, you would take a little flatter than the average. Okay, so let's say it's the corneal value, the values are 7.8. You take it in millimeters, by the way, and let's say it's 7 and 7.4. So, or 7 and 8, sorry. So the average would be 7.5. In a if you want a good three-point touch, the starting point would be something like 7.7. So this is the most frequently advocated design for keratoconus. However, may not be able to fit many patients, and it is very good for early to moderate keratoconus, but not so much for advanced keratoconus. It's a relatively flat fitting method in which the contact lens leans on a relatively large area. So as I said, it's relatively flat. So you go slightly flatter than the average, and then you evaluate the lens fitting, starting with that lens, and then you go either further flatter or steeper depending on the fit that you obtained. And there is a mild feather touch. It's called a very light, just faint touch. It's called a feather touch over the cone apex, accompanied by at least 2 other areas of touch at the central mid-periphery. So therefore 4 zones are created: a central slight apical touch, paracentral clearance where you can see the dye, then a mid-peripheral bearing where again there is contact, so no dye, and peripheral clearance where there is again dye seen. So let's look at this. This is the light central area, the feather touch. This is the paracentral area where the dye is pulling in because there is clearance. Then this zone is the area of bearing again, mid-peripheral, and the peripheral area of clearance where the lens is lifted off, and it is very important that there is peripheral clearance and dye is pooling there, otherwise the lens will get sealed and stuck. So another picture of 3-point touch, you can see a light feather touch here, paracentral bearing, mid-peripheral clearing and peripheral clearing. Sorry, mid-peripheral bearing and peripheral clearing. So we come to the next fitting pattern called apical bearing. A large diameter lens with flat base curve is fitted, that is flatter than flat. So if in the first example I said 7 and 8, you would probably start with 8.2. You go flatter than the flatter K. The lens rests on the corneal apex. This flat fitting method places almost the entire weight of the lens on the cone, and this tends to be held in position by the upper lid. So in this kind of fit, it is important to have a contact between the upper lid and the contact lens, because the upper lid will pull the lens up with a blink, and that is what is holding the lens there. The fluorescent pattern shows excessive central bearing. See, there's a large area compared to the last one. This is a large area of bearing. That means this area is whole under contact. The lens is held there. Then you have mid-peripheral area of clearing, and inferiorly there's a lot of pooling there because it's so flat and the cornea is so steep. The dye is pooling there, and this is called an edge standoff or edge lift. And the good thing about these lenses is that they provide probably the best visual acuity. A flat fitting lens can provide a very good visual acuity because the tear lens functioning is enhanced in this fitting. And as I said, there's a wide standoff which cannot be eliminated in advanced cases. Again, another apical bearing. This is the edge standoff that I was talking about. So then coming to alignment can be obtained in early keratoconus also, but it is primarily used for moderate to advanced. It is believed to cause progression and acceleration of apical changes due to micro trauma, and because there is excessive pressure on the apex, it can cause distortion, scarring and swirl staining, but it is useful for advanced cones and displaced cones. This is what I was talking about, the swirl staining. It is because there is constant micro trauma. Looking at apical clearance, can I have a little more time? About 2-3 minutes? In apical clearance, a small steep lens is fitted. The lens leans on the slope of the cone. You can imagine it's because there's central clearing, you have a steep cornea and the lens is going to be steeper than that. So there's lens leans on the slope of the cone and vaults over the thinned apex, and there's therefore pooling in between. There is no mechanical rubbing on the thin corneal apex, therefore causing less scarring. So the issue with this apical bearing that we had, that it causes scarring and possible progression, some workers believe, is eliminated in this, but this has its own set of problems. But it is important to monitor the fluorescent pattern to ensure that the peripheral seal off, as I mentioned, the lens may get sealed and adherence of lens to the cornea does not occur. Because if that occurs, there would be hypoxia and corneal damage. In this type of fitting technique, the lens volts the cone and clears the central cornea, resting on the paracentral cornea. These lenses tend to be smaller in diameter and therefore have smaller optic zones, which thereby results in the glare phenomena or glare problems. There is potential advantages of reducing central corneal scarring are outweighed by the disadvantages of poor tear film and tear exchange, corneal edema, and poor visual acuity as a result of bubbles becoming trapped under the lens. This is again apical clearance. You see this, and this bubble in between, in the center, means it's a steep cornea. Peripheral bubbles which come and go may mean a flat fitting cornea. So this is a steep fitting cornea and therefore is not a good fit. Another apical clearance, decent fitting apical clearance. So the suggested fit preference is you try to start and obtain a 3-point touch. In case you cannot do that, if the cornea is moderately advanced or very advanced, then apical bearing, followed by the last one, which is the last resort, apical clearance. After achieving the desired fit, we do an over-refraction to determine the final contact lens power, and moderate to high decay RGP material lens is ordered. A decay 60 or decay 90 would do very well. I don't personally prefer very high decay values because the lens material gets softer and there's increased warpage and lens replacement requirement. So the fitting process in advanced keratoconus is, because due to varying peripheral corneal topographies, no single lens design in advanced keratoconus or fitting philosophy will universally result in an optimal fit. Different fitting approaches may be employed. Whatever works, you have to use that based on the central and mid-peripheral corneal topography. In advanced keratoconus, we have to give apical bearing despite some micro trauma occurring, because otherwise the patient may not be able to get the benefit of good visual acuity. The criteria for a well-fitted lens is a good fit, stable lens, good maximum obtainable visual acuity in all waking hours, wearing time, and no corneal erosions. It is important to train the patients because good fitting is just the first step. There are many patient dropouts due to various factors. One, they do not understand. Two, it's a cumbersome process initially. Three, it requires adaptation process which can take anything between 2 to 3 weeks for the patient to get used to it. So patients have to be taught the proper usage of contact lenses. They have to be taught about the hygiene required, the cleaning protocol, and insertion and removal techniques which can be an issue for the first time user. Inform about replacement schedules, because patients, you realize sometimes they come back after 4 or 5 years and you haven't probably really, you may have said you have to come back for a replacement in 1 or 2 years, but they don't understand that. Schedule regular follow visits for at least the first 6 months. In conclusion, RGP lenses are a very good modality for visual rehabilitation in keratoconus patients and other irregular or high astigmatism. They are often the mainstay of therapy, although newer options are coming in. Now, like the surgical options, important to have a good rapport with the patient to tie over the initial difficulties and discomfort associated with RGP use. Thank you for a patient hearing.
Thank you, Dr. Ashu. Now I request Dr. Kirti Singh to present on contact lens and corneal scars.
Thank you. At the outset, I'd like to thank Dr. Rajesh for having me here. So I'll be covering 2 topics in succession. First one, contact lenses fitting in corneal scars, and the second one would be care and maintenance. So if you have any questions at the end of the 2 sessions, you can have the questions for that. So the first topic is, I call them broken corneas, the one with corneal scars. I have no financial interest to declare. Now the normal cornea, as you know, is an aspheric regular cornea. And I've used bonsai to demonstrate to you what the normal cornea looks like. However, once the cornea is broken, the topography is altered. In that case, to fit a lens on this broken topography is difficult, because the lens, by fabrication, by design, is meant to be fitted on a aspheric cornea. So these are the type of corneas which we deal with in our clinic. Now, my talk will be based on 3 types of fitting which we've done over the last 10-15 years. We had a series of patients with corneal scars and opacities, almost 112 patients. Trauma comprised 71%, post-inflammatory ectasias and scars 23%, and post-surgery 5%. These were some of the bad cases with such scars, and they were very often, unfortunately, children whose whole life depended on their reading abilities, and for that no spectacles were possible, so contact lens fitting was our wish and mandate to do. These scars were not so bad. What does the contact lens essentially do? It converts the irregular astigmatism which is seen in the pre-fit topography, and this is a topography taken with the contact lens on. So it converts the pre-fit irregular astigmatism into a regular surface. In our series, we could have success in almost 71%. Mean improvement was more than 3 lines. Median was 4 lines. However, it took us a long time. Average trials were at least 3, with the range from 1 to 7. Now, the patients who improved were 21% aphakic, 9% pseudophakic, rest were phakic. Which patients did not improve? We should know that we don't attempt too much in those patients and straight away refer for a keratoplasty. With those with a very dense corneal scar and 5 cases had amblyopia. Now, in these children, if you leave these scars untreated for a long time, you don't rehabilitate them. By the time you end up rehabilitating them, they have dense amblyopia, so it doesn't work out. So these are the type of patients we had seen. These are the patients with the corneal scar with the nebular macular opacity, and they did pretty well. The other ones were the dense scars, so the bisecting scar, and this also is a vertically bisecting scar with an RGP lens on, and this is the one with an RGP lens on, and this lens, as you can see, cannot be centered. Leukomatous opacities, you try to fit them, but in this patient, what we ultimately did was we did a photomydriasis for this patient. So we dilated the pupil, and this patient could ultimately see, and he was waiting for keratoplasty, and which he went for ultimately. The other series, so the first series was the post-traumatic scars. Second was the post-traumatic monocular aphakic eyes. Now for these aphakic patients, for the previous series we could put the RGP lens or the soft lens, but for these monocular aphakic people, especially children, 70% were children, as I said, you have to ensure binocularity with the normal eye. So spectacles cannot ever be an option, it has to be a contact lens. And these patients, we fitted both soft lenses and RGP lenses. You would say in aphakic children's RGP lenses are difficult. Yes, they are difficult, but they are absolutely not infeasible. It is a possibility. We should just be patient and keep trying to do it. So these are some children in which we fitted contact lenses instead of those heavy, cumbersome spectacles. But please remember that in children, some anatomical and physiological variations from adults which we need to remember while fitting contact lenses, that in children, the normal diameter of the cornea is 10 millimeters. Now the standard soft contact lens parameters diameter would be 13.5. So you have to get it custom made. They only reach a diameter of 11.7 at 1 year. So if you put an adult contact lens for a child, you're going to have problems. So you have to have a designed lens for a child which is geared up for this diameter. Radius of a child is 7.1 mm, and for an adult it's 7.8. So thus these children need steeper lenses. Axil length of a child is smaller, so smaller, steeper and stronger lenses are required for children vis-a-vis adults. However, the corneal endothelium is very healthy, it's dense, and it withstands hypoxia better. However, tears have less mucus, more water. Blink rate in a child is very less. Children sleep very much. They sleep for long times, and child's world primarily is near. So you have to focus for near and dear, and you have to plan for blinking. You can't ask the child to blink. So you have to put frequent lubricant drops and arrange for a lens which is hydrophilic. That is why silicone lenses, although were very good in oxygen permeability, were not very successful because they were hydrophobic. Why has it gone back? I'm sorry. Excuse me. Yeah, I got it. ये button नीचे है. This was the one. Yeah. Okay. Now, how do you assess the fit? In children, again, they will not say कि आप blink करो and the child will blink. It will not happen. So you have to assess by dynamic fit. You ask the patient. We have toys in our clinic. We ask the children to move. Look at the toys. The mother sits with them, and you ask the children to look at the toys and then assess the movement of the lens. And then you can't really do the fluorescein fitting for an RGP lens in a child very well. It has to be a dynamic fitting pattern which we see. So I don't know if it's visible there. Now in this child, on looking up, the lens is lagging behind. So this is a flat lens. Good. And in this child, on lateral movements, as Rajesh was telling you, this is up movement and lateral movements. This seems to be almost okay, but this is a little larger lens. So again, you have to redesign this lens with a smaller overall diameter. This is an RGP lens. It's a very, very flat. It is an okay fitting lens, but it has an axial edge lift. So you have to redesign the edge lift for this patient. This is an extended wear lens. It is sagging down. Okay, so this is a very, very flat lens, and this lens is designed for adult wear. So if you reduce the diameter and do the base curve correction, this lens will fit. This lens is an RGP lens, and the patient is looking up, it's moving well. So this slide I showed you just to get rid of that fear or the phobia that we cannot fit RGP lenses in children. Yes, you can. All of us can fit, we just require the patience to keep doing it. The parameters we used were extended wear hydrogels, which were used at a daily wear basis. Please don't prescribe the extended wear to a child and tell the mother ki remove after 1 week. Do not ever do it. Use an EW lens, but use it on a daily wear basis because risk of infection is very high. As I said, blinking is poor. Hygiene necessarily of children is very poor, and the second thing is the tears are more viscous, so the infection rate can be very high. RGP can be used in little older children. The lens profile was you calculate by over refraction, and please remember, a young child, there will be a very rapid myopic shift, so you tell the parents that every 3 months the child's lens has to be changed. So if you tell them 3 months, you do it 6 months, they won't tell you that, doctor, you never told us before that you will require 3 lenses in 1 year's time. Follow up initially weekly for a month, then fortnightly, then 3 monthly. So it requires a very meticulous and a very stringent follow-up. Refractions have to be repeated 3 monthly in the first year, and then later 6 monthly, and then maybe you can switch to a yearly refraction. Lens loss, please anticipate that there will be 3 to 5 in an initial year. Backup pair of spectacles if it's a bilateral effect. If it's a uniocular case, then you can't have a backup pair of spectacles. You have to have a backup pair of lenses. In children, it's a double whammy. You have a problem of amblyopia, so you need to do the patching. The patching can be by different ways, either by opticlude patching, which comes in different colors and prints, or you can have the Duonis occluder. But patching has to be part and parcel of your contact lens fitting. Otherwise, what are we aiming for is vision in a child, and despite our best contact lens fitting, we won't be able to give vision unless we do the amblyopia treatment. Another things which I ask my patients to do is I give the children these type of colored puzzle books. They're all very expensive. It just costs around 80 to 100 rupees, and the mother colors them with felt pens and things, and the child just keeps fitting the puzzles in. So that gives them a exercise to do with the contact lens on. Do I have time, Rajesh? Do I have? Okay. So you monitor also for another thing which I have seen in the phakic corneal scar patients is the phakic glaucoma. How do you assess that? Now what will happen is the pressures may be difficult to assess in a small child. When you do the refractions, when you do it 6 monthly, you'll find a more rapid myopic shift because the axial length is enlarging. So if you see a myopic shift more than required, please go ahead and go and check for pressures with Perkins or whatever technique you have, and check for the disc damage. Disc damage may not occur in the early stages, so pressures have to be checked, but keep this warning in your mind that glaucoma is a big possibility in these children, and you have to keep checking it out by the rapid myopic shift. Then these children often land up with squinting and nystagmus. That means you have inadequate correction of the lens and the inadequate centering of the lens or inadequate compliance. The mother comes to you, yes doctor, I've been putting the child with the contact lens for 6 hours a day, and you find that the child is squinting. That means that the mother actually is not putting the lens. Or when you put the lens on and you find the lens is decentered, it is not actually in the position because the lens has overgrown the child. So next thing you remember is for phakic corneal scars that you must have bifocals for the school-going children. You would need that bifocals which are executive type for the school-going children for them to have adequate binocularity. Otherwise you land up with these squinting type of kids. Complications, you can have infective keratitis as for any contact lens, hypoxia with a red itchy eye, tearing, giant papillary conjunctivitis. Less prinking, so drying and stuck on lens is very common. So then you tell the mother that if the child's lens is you are unable to remove it, then put the lubricating drops, wait and then try to remove, or if still not possible, come back to the clinic and get it done. Deposits are more prone and neovascularizations. So salient points in corneal scar fitting, especially for children, are fit steeper, smaller, assessed by movement, centration, thicker lenses because they're aphakic, so need freer movements. Astigmatism, somebody had asked us about astigmatism. In children, you can ignore it. Now these corneal scars may have a cylinder of 3 to 4. But if you start correcting by toric lenses, it's not possible. RGP sometimes may not be possible. Then in those cases, you ignore the astigmatism, just aim for a spherical correction. Something is better than nothing. Then the third group which we fitted was the post-keratoplasty, which had infections, and these scars were there in the post-PK patients. These were 25 eyes. Range of cylinder was up till 19 cylinder. Mean was of 9 to 10 of a cylinder. Now for the keratoplasty patient with corneal scars, you need the lenses of a larger diameter. Only RGP lens fitting is possible in this. So lenses of a larger diameter, always more than 9.4. If you have poor centration, go for even larger and steeper contact lens. Over-refraction has to be verified at 2 separate occasions on 2 separate days. Why am I stressing that is, if you're in a very busy practice, you do the contact lens fitting and do the refraction on a keratoplasty patient, because the movement of the lens with time will change in 2-3 days, the watering will change, so it is preferable before finalizing the lens that you call the patient again, better after 2-3 days, and then verify the over-refraction and then prescribe the lens. Centration is poor in eccentric graft and excessive asymmetry. In PKIs, you prefer a flatter fit with a higher decay to lesser compromise the corneal endothelium. So these were some of our patients with eccentric grafts. Okay, so this is the topography of those patients. This was a patient which we really couldn't fit very well. It was a 25 cylinder. So this graft is so eccentric that no contact lens can fit, so only a resurgery is the option. And in PK, with time, you normally fit the lens after 6 months or 1 year, or preferably after suture removal. But sometimes that is not an option, so as suture removal is done or as healing happens, the axis changes. So your lens fitting perforce also will change. So keep that in mind when fitting these patients. Now so this was the study which we had published. Conclusions: contact lens corrects irregular astigmatism caused by corneal scars by creating a new corneal surface. Associated uniocular aphakia, pseudophakia, which is a very common scenario in these trauma patients, enables binocularity with the normal eye, and it's extremely useful option in traumatic corneal scars with aphakia. It reduces the load of patients on penetrating keratoplasty and the long interminable waiting period for PK in our country, not to mention the risk of graft infection, rejection. Use of steroids makes contact lens fitting a very, very viable option. So please, when you remember these broken corneas, try to think out of the box, dare to innovate, fit contact lenses. It is absolutely possible. My next topic would be...
Okay. Meanwhile, as we have covered the fitting of contact lens, if we have any query related to fitting, you can ask. Like we have done the soft contact lens fitting, we have done the RGP contact lens fitting, we have done it on the scars, pediatric cases. So if we have any query related to fitting, then you can ask now, and then we can go ahead to care and maintenance after that.
As far as neonates or premature babies are concerned, once they undergo surgery for cataract or something like that, contact lens should be given for how much time, and what is the diameter of those lenses?
Yeah.
You want the premature infants who've gone cataract surgery, so I assume there's no ROP. Please remember, when we are fitting a contact lens in the child's anatomical parameters and the needs are different, so please evaluate the fundus first. So ROP is out, you're fitting for a premature child. It's very difficult because custom-made lenses for these children have to be necessarily very small. And especially if it's a uniocular patient. In fact, I remember long ago when I was in Great Ormond Street Hospital, A similar child had come with unilateral ROP with cataract, and a very famous ophthalmologist told the patient's mother, better to leave the child alone, don't do anything. It was that bad. The geniocular patients were not even tried, not even attempted. However, I don't agree with that mandate. You attempt it, you do the fitting. I normally use a hydrogel lens, extended wear. I don't have access to silicone lenses because that will costly, and I find the hydrophobicity of the silicone lenses is so much that very often the mother forgets to put the drops. They get a stuck-on lens. So I use a hydrogel lens, extended wear. I fit it, cataract surgery within 2 to 3 weeks. Within 2 to 3 weeks, I make the mother come to my clinic, sit with me, put the lens on, keep the child, she can feed the child and just sit with him for at least 1 or 2 hours. And then I re-evaluate the fit on the eye after 15 minutes. Because lens will steepen on the eye, it tightens on the eye. And if you don't evaluate that, you'll end up, the mother ringing you up after 2 days, very frantic, doctor, the eye is very red, I can't remove it because you haven't evaluated properly. So make the child sit with you for half an hour minimum, and then re-evaluate the fit, preferably after 1 hour, minimum half an hour, and then prescribe by over-refraction. Child will not cooperate. So you have to get the refraction first under atropine, and then after the lens is on by over refraction. Aphakic refraction is not very difficult to do actually. So the glow is pretty good, and you finalize by over refraction, correct for near. A very small child, even if you undercorrect or overcorrect, won't make much of a difference. It's a basic thing is that binocularity has to be established and amblyopia has to be prevented.
Any other query? Well, I'll request Dr. Kirti now to go ahead with the care and maintenance of contact lens.
Okay, thank you. The care and maintenance, I'll be taking it. I want to highlight one is the contact lens care. For that, please keep one tip in mind is always check on the contact lens case. When the patient comes to you, ask them to bring their case with them. Why? I'll tell you this thing. I have no financial interest to declare. Now, I'll be covering the care of contact lens and maintenance in 4 aspects, because these are the 4 aspects which will cause complications. So basically, all the care and maintenance is to prevent complications and to give visual gain.